The core insight many people miss about asthma isn't just about managing the symptoms day to day. It's understanding that the whole landscape of treatment, it's kind of undergoing this quiet revolution.
That's a good way to put it, yeah.
Shifting from just, reacting to crises to being really proactive, even predictive.
Yeah.
You've probably seen them, right? The asthma inhalers, medications. It can feel like a tangled web. All those names, colors, different devices.
Oh, definitely.
But what if we told you there's a clearer path through it all, a way to really grasp this vital information, maybe for yourself or, for people you care about?
And what's truly transformative here, I think, is recognizing the sheer amount of innovation that's actually happening.
Right.
And how understanding these shifts, even the subtle ones, can really empower you. It moves you beyond just sort of coping with asthma to actually taking control.
That's exactly it. So our mission in this deep dive, let's untangle all that. The different types of asthma meds, the clever devices that get them where they need to go.
The crucial bit.
And even the really cutting-edge digital tech that's starting to change how asthma is managed. By the end, you'll have the kind of insights you need to have, much more informed chats with your doctor or nurse.
Sounds good.
Okay, so let's start right at the beginning. What is asthma actually doing inside your body? What makes breathing so hard?
Right. So picture your airways, like little tubes or pipes going into your lungs.
Yeah.
In asthma, two main things go wrong. First, the muscles wrapped around those tubes, they squeeze tight. Constriction.
Like squeezing a hose pipe.
Exactly. And second, the inside lining of those tubes gets swollen and inflamed. Mucosal edema, we call it.
So it's narrower from the outside and blocked from the inside.
Precisely. Like that hose pipe being squeezed and getting clogged up inside leaves very little room for air. Makes breathing a real struggle.
And that explains why inhalers are usually the first thing doctors reach for.
It does. Think of them as a highly targeted delivery system. It's not like swallowing a pill, that has to go through your whole system.
Right, the whole body gets a dose.
Exactly. Inhalers shoot the medicine straight into those tight, swollen airways.
Direct hit.
And because it's so targeted, you need much, much smaller doses, which is great because that means far fewer side effects. Very little medicine escapes into the rest of the body. It's just incredibly efficient.
Okay. So inside these inhalers, what are we actually dealing with? You mentioned two main types.
Yeah, the foundational categories are usually relievers and preventers.
Relievers and preventers, got it.
And just a quick note, you'll hear the official drug name, the generic name.
Like salbutamol.
Right. But then there are loads of brand names like Ventolin, Aeromir that can add a layer of confusion sometimes.
Okay, so let's tackle relievers first. The short-acting ones, SABAs.
Yep, short-acting beta agonists, SABAs. So how do these little powerhouses work? Feels like it sometimes. They basically tell those squeezed muscles around your airways to just relax, open things up, and it happens fast. You use them when needed, For that sudden breathlessness or wheezing or tightness in your chest, relief usually kicks in pretty quickly.
And salbutamol, Ventolin, that's the common one, usually blue.
That's the most common one, yeah. So butamol, brands like Ventolin, Aeromir, Salamol, and terbutaline, Bricanol is the brand name there.
Yeah.
They often are blue, but really important. Always check the label.
Good point. Not all blue ones are relievers.
Correct. Now, here's a really crucial update, something that changed fairly recently, 2024 in the UK.
Okay.
Reliever inhalers. They should not be the only treatment for asthma anymore.
Right. That's a big shift. Why?
Because the deep insight here is, while they're great for that immediate fix, they do absolutely nothing for the underlying inflammation.
The swelling.
The swelling. That's the chronic problem in asthma. That's what causes the long-term damage and sets you up for future attacks. Relying only on the reliever is just papering over the cracks.
So that leads us to the other type.
Exactly. It leads us straight to the preventer inhalers.
Okay. Preventers. Usually steroids, right? ICSs.
Typically, yes.
Yeah.
Inhaled corticosteroids, or ICSs. Their job is completely different. Preventers are your daily defense shield.
Okay.
You take them every single day, usually twice a day, to stop attacks from happening in the first place and keep symptoms down.
So they work on that inflammation.
Precisely.
Yeah.
They reduce the swelling in the airways, make them less twitchy, less likely to narrow.
And the real game changer here, I guess, isn't just the physical effect. It's moving away from constantly worrying about an attack.
That's a huge part of it. Living with that constant fear versus achieving a baseline where asthma just isn't really on your radar day to day.
But they don't work instantly like the blue one.
No. Absolutely not. No immediate relief. It takes time for them to build up their effect, usually about 7 to 14 days to start seeing benefits,
Okay.
and maybe up to 6 weeks for the full effect.
Hmm.
So patience is key.
And what are the common ones? You see brown ones, red ones.
Yeah, colors vary again, but common steroid preventers are beclomethasone, often in brown or red inhalers like clenilmodulite or QR,
Mm-hmm.
Butzenide, which is in Bulmacort, and fluticasone. Flixitide is a common brand, often yellow or orange.
So the goal with these is if they're working properly.
If your asthma is well controlled with your daily preventer, you should only need your reliever, your blue inhaler, very occasionally.
How occasionally is occasionally?
Ideally, almost never. Certainly not more than, say, 2 and 3 times a week. If you are reaching for that reliever often,
It's a warning sign.
it's a big red flag that your underlying inflammation isn't controlled. Your preventer strategy needs adjusting. Definitely time to talk to your doctor or asthma nurse.
Okay. But what if the preventer steroid alone isn't quite enough?
Good question. That's often when we add another type of long-term medication, long-acting bronchodilators, or laybase.
Oh, laybase. So like the relievers, but long-acting.
Exactly. Similar muscle-relaxing action, but the effect lasts much longer, usually up to 12 hours.
Ah, so they keep the airways open for longer stretches?
Right. Helps prevent symptoms overnight or during the day. Examples you might hear are Salmeterol Cervantes, the brand, and Formoterol.
Okay.
But here's a really crucial safety point with lepilambases. They've been linked to severe asthma attacks if they're used on their own.
Really? Why's that?
Because, again, they open the airways, but they don't treat the inflammation. So you might feel better, but the underlying problem is still simmering away, potentially getting worse without you realizing.
So you must use them with.
They should only ever be used alongside an inhaled corticosteroid, that preventer steroid we talked about. They work as a team.
Yeah.
The steroid tackles the inflammation. The lepilamine keeps the airways open.
Which leads perfectly into combination inhalers, I suppose.
Exactly. They simplify things a lot. These clever devices put both the inhaled steroid and the long-acting bronchodilator into one single inhaler.
Ah, convenient.
Very. You get both medicines with each puff. Common ones include Foster, which has formoterol and beclomethasone. Seretide, that's often purple, has salmeterol and fluticasone. Sympacort combines formoterol and Butzenide.
Lots of names and colors again.
It is. So again, a practical tip. Try to remember both the name and the color of your specific inhaler. Maybe keep a little list on your phone or wallet. It can really help.
Good idea. Are there other long-term controller types?
Yes. Briefly, there are also long-acting muscarinic antagonists, or LAMAs, another type of bronchodilator. Tiotropium, in the Spiriva respirati, is an example. They're sometimes added on for people with more severe asthma that's still not controlled.
Okay, so mostly inhalers. But what about pills? You hear about people taking steroid tablets sometimes.
Right. So while inhalers are the mainstay, targeting the lungs directly, sometimes we need a more systemic approach. That's where oral medications come in. But like you say, with important considerations.
Particularly oral corticosteroids like prednisone.
Exactly. Prednisolone. Their main role is usually for a severe asthma attack, like using a fire extinguisher to quickly douse widespread inflammation throughout the body.
Okay, a short, sharp burst.
Often, yes, a short course. Or sometimes they're used longer term for very severe, difficult to control asthma when other medicines just aren't cutting it.
But the side effects are the big worry here, aren't they, compared to inhaled steroids?
Absolutely crucial difference.
Okay.
Because you swallow them, oral steroids affect your entire body, not just the lungs.
Right.
So the potential for side effects is much, much higher. Short term, you might get things like acne, weight gain, mood changes, trouble sleeping.
Annoying stuff.
Definitely bothersome. But the real concern is with long-term use. That carries risks of more serious problems. Osteoporosis, cataracts, increased risk of infections, diabetes, high blood pressure, even changes in appearance like moon face.
Wow. Okay, so definitely used carefully.
Very carefully. Like that fire extinguisher analogy, essential for a major blaze, but you wouldn't use it for a tiny spark every day. Minimizing oral steroid use is always a major goal in asthma management.
Got it. Any other oral meds to know about?
There are leukotriene modifiers. Montelukast is the main one. It's a tablet taken once daily to help prevent symptoms over 24 hours. Works differently to steroids.
Is it common?
Reasonably common, yeah.
Yeah.
It can be helpful for some people, especially if allergies play a big role. But it's worth knowing Montelukast has been linked, in rare cases, to some psychological reactions, mood changes, sleep disturbances. Something doctors watch out for.
Okay. And what about allergies specifically, if that's your main trigger?
Right. For allergy-induced asthma, there are specific treatments targeting the allergy itself. Allergy shots or immunotherapy.
The ones where you get injections over time?
Yeah, a long-term process, gradually desensitizing your immune system to specific allergens like pollen or dust mites. There are also under-the-tongue tablets now, sublingual immunotherapy, which is a needle-free option.
So they treat the root cause of the allergic reaction.
Exactly. But important clarification, general allergy meds like antihistamine pills or nasal sprays, they can help with hay fever symptoms, runny nose, itchy eyes.
But not the asthma itself.
Correct. They are not substitutes for your actual asthma inhalers. They don't treat the airway inflammation. Managing the allergy helps, but you still need your core asthma meds.
Makes sense. Now, what about the really severe end of the spectrum? Are there newer options?
Yes, absolutely. This is where biologics come in, a relatively newer class of drugs that have been, frankly, life-changing for many people with severe asthma.
Biologics, how do they work?
Think of your immune system like a complex army. In severe asthma, sometimes specific parts of that army go rogue, causing excessive inflammation. Biologics are like highly specific smart missiles.
Okay.
They're designed to target and neutralize only those specific rogue immune cells or signals that are driving the inflammation without suppressing the whole immune system.
Very targeted.
Extremely targeted. For example, for severe allergic asthma, there's omalizumab, brand name Xolair. It works by blocking IgE, an antibody involved in allergic reactions. For severe eosinophilic asthma, that's where you have high levels of a specific white blood cell called eosinophils. There are biologics that target those cells or the signals controlling them.
And are they injections?
Yes, typically given as injections every few weeks or months. There's also a newer one, tezepelumab echo, or Testatir, which is interesting because it seems to work for both allergic and eosinophilic types in some people. Offers broader potential.
Amazing advancements, but obviously for the more severe cases.
Definitely reserved for severe asthma that isn't controlled by high doses of standard inhaled therapies.
Okay, so we have all these different medications, relievers, preventers, LBs, combinations, pills, biologics, but knowing what they are is one thing. How doctors actually use them, the strategy, that seems key.
Absolutely. The regime is crucial, and it's really evolved over time, becoming much smarter.
So what are the main approaches people might encounter?
Well, let's start with what's out. For a long time, especially for mild asthma, just using a reliever inhaler whenever you felt symptoms was common. As needed reliever only.
The blue one, just when you need it.
Right. But, as we discussed, UK guidelines changed in 2024. That approach is no longer recommended.
Because it doesn't treat the inflammation.
Precisely. It's just symptom relief, not disease control. It leaves you vulnerable. So the new thinking for mild asthma is something called anti-inflammatory reliever therapy, or AR.
AR therapy. What's that?
It usually involves using a combination inhaler, one that contains both a fast-acting reliever and a low-dose inhaled steroid.
Ah, like Symbicort or Foster?
Exactly.
Yeah.
But you only use it when you have symptoms. So every time you need relief, you're not just opening the airways, you're also getting a dose of anti-inflammatory steroid right where it's needed.
So it nips the inflammation in the bud each time.
That's the idea. Quick relief plus tackling the underlying issue simultaneously. It's a really smart approach for mild asthma.
Okay. What about the more traditional approach?
That's still very widely used, especially for moderate asthma. It's the regular preventer and as-needed reliever regime.
So daily preventer, blue one for emergencies.
Yep. You take your preventer inhaler, usually the steroid one, every single day, morning and night, even when you feel perfectly fine. That's your baseline control. Then you only use your separate reliever inhaler, the SABA, for breakthrough symptoms or flare-ups.
And the goal is?
The goal is to need that reliever very infrequently. Remember, if you're using it more than, say, 2 or 3 days a week.
Red flag again.
Big red flag. Your asthma isn't well controlled, your preventer dose might need adjusting, or maybe your technique isn't right. Time for that conversation with your doctor.
Right. And you mentioned MART therapy.
Yes, MART stands for Maintenance and Reliever Therapy. This is often the preferred regime now for moderate to severe asthma.
How does that work?
With MART, you use a single combination inhaler again, one containing both an inhaled steroid and a specific type of long-acting reliever called formoterol, which also acts quickly.
Okay.
You take it regularly every day for your maintenance dose, your prevention.
Right, the daily dose.
And you use the same inhaler if you get symptoms or have an attack. You take extra puffs as needed for relief.
Ah, so one inhaler does both jobs.
Exactly. It simplifies things hugely. Just one device to carry, one technique to learn. And studies show it's very effective, often better than the separate preventer-reliever approach for controlling asthma and preventing severe attacks.
That sounds really practical.
It is. It empowers you to adjust your treatment slightly based on your symptoms while ensuring you always get that essential steroid dose alongside the reliever component.
Okay, fantastic overview of the strategy. So we've got the medicines, we've got the plans, but what about the actual thing you hold in your hand, the inhaler device itself? That's got to be important too.
Oh, hugely important. Getting the medicine from the canister into your lungs effectively. And that's the whole point, right? The device is just as critical as the drug inside it. Proper delivery is absolutely key.
So what are the main types of devices we should know about?
Well, the most common type, the one people picture, is probably the pressurized meter dose inhaler, the MDI.
The standard puff.
The standard puffer, exactly. Been around for decades. Quick, portable. It uses a pressurized gas, a propellant, to push out a measured dose, a puff, of medicine when you press the canister.
Simple enough.
Sounds simple, but the main challenge is coordination. You have to press down and breathe in slowly and deeply at exactly the right moment.
Tricky.
A lot of people find it surprisingly difficult. Common mistakes are not shaking it first, breathing in too fast, not holding your breath long enough afterwards. A lot of the medicine can end up impacting the back of your throat instead of getting down into the lungs.
Which is why you often see them used with
spacers. Yes, we'll definitely come back to those. But first, other device types. There are breath-activated inhalers.
So they puff automatically when you breathe in?
Some do, yes.
Yeah.
Some are still MDIs, like the auto howler or easy breathe, but they sense your inhalation and trigger the dose automatically. Takes the coordination issue away.
Okay.
Others are dry powder inhalers or DPIs. These are quite different. Things like AccuHowlers, turbohalers, ellipta, twisthalers.
Right, you hear those names. No gas.
No propellant gas. The medicine is a very fine dry powder inside the device. You usually have to load a dose, maybe by sliding a lever or twisting the base. Then your breath, as you take a strong, deep inhale through the mouthpiece, pulls the powder out and down into your lungs.
So you need a good, strong breath in for those.
Yes, you need a reasonably forceful inhalation. They generally require less coordination than a standard MDI, but you do need that good inspiratory effort. Might not be suitable for very young children or someone having a very severe attack.
Any others?
There are also soft mist inhalers, like the Respimat device. These use liquid medicine, but create a very fine, slow-moving mist when activated. Many people find the mist easier and more comfortable to inhale than the spray from an MDI or the powder from a DPI.
Okay, lots of options. Now back to those spacer devices. You said they're important, especially with the standard MDIs.
Vital is the word I'd use. Honestly, they're often really underestimated. A spacer is basically a plastic or metal chamber, like an extension tube, that fits onto the mouthpiece of your MDI.
And why is it so vital?
Two main reasons. First, it dramatically increases the amount of medicine that actually reaches deep into your lungs where it needs to work. Sometimes by up to 70%.
70%? Wow.
Yeah. Instead of hitting the back of your throat, the medicine cloud slows down in the spacer chamber, and the smaller, more affected particles stay suspended, ready for you to breathe them in gently.
So it overcomes that coordination problem.
Exactly. You press the puffer once into the spacer, then you have time to just breathe in slowly and deeply from the spacer's mouthpiece. Much easier.
And the second reason?
Reduce side effects. Because less medicine gets deposited in your mouth and throat and swallowed.
Ah, so less chance of a sore throat or oral thrush with inhaled steroids.
Precisely. And less medicine absorbed into the body systemically. So better effect in the lungs, fewer problems elsewhere. It's a win-win.
Everyone using an MDI should use one then.
Ideally, yes, especially when at home. They can be a bit bulky to carry around all the time, but for regular doses, definitely. And for children, they're essential with MDIs. You can even get spacers with face masks for babies and very young kids.
Any tips for using them properly?
Key things. Shake the MDI well first. One puff into the spacer at a time. Breathe in from the spacer as soon as possible after puffing. Hold your breath for about 10 seconds or as long as comfortable. If you can't hold your breath, just breathing in and out normally through the spacer mouthpiece for a few breaths works too.
And cleaning them.
Ah, yes. Important. Yeah. Wash them regularly, maybe monthly, just with warm water and normal washing up liquid. Critically, let them air dry completely. Don't rinse the detergent off, and don't wipe them dry with a cloth or paper towel.
Why not?
Rinsing or wiping can create static electricity inside the plastic spacer, which makes the medicine particles stick to the sides instead of being available for you to inhale.
Huh.
The thin layer of detergent helps prevent that static.
Fascinating detail. What about nebulizers? You see them in hospitals sometimes.
Yes, nebulizers. They're machines that turn liquid medicine into a fine mist, which you breathe in through a mask or mouthpiece over several minutes.
Are they better than inhalers?
Not necessarily more effective for delivering the same dose, no. Their main use is in emergency situations, like a severe asthma attack in hospital, when someone is too breathless or distressed to use a standard inhaler properly, or when very large doses of medication are needed quickly. They don't require much cooperation from the patient.
So not really for routine home use anymore.
Much less common now for home use. Good inhaler technique, especially using an MDI with a spacer, is generally just as effective, much quicker, more portable, and cheaper. Modern spacers have really reduced the need for home nebulizers.
Okay. So choosing the right device is clearly a conversation to have with your doctor or nurse too.
Absolutely. Depends on the medicine prescribed. Your age kids under 6 often struggle with DPIs, for instance. It depends on your coordination, your inspiratory strength, even personal preference and convenience. There's no single best device for everyone.
Trying them out might help.
Definitely. Healthcare providers can demonstrate the different types, check your technique, and help you find the one that works best for you.
Because ultimately, it's about getting that medicine reliably to the lungs.
That's the bottom line. Consistent, proper technique with whichever device you use is absolutely essential. It's the bridge that makes the medicine work.
Right. Now, if we thought the evolution of meds and devices was something, technology is taking another leap, isn't it? This is where it gets really interesting. Digital inhalers. What if your inhaler could actually talk to your phone? And maybe even your doctor. It sounds futuristic, but it's happening now.
It is. It's a fascinating development, really tackling those persistent challenges of remembering to take medication consistently, adherence, and using the inhaler correctly.
So what is a digital inhaler? Is it a whole new device?
Sometimes it's integrated. Sometimes it's a small sensor you attach to your existing standard inhaler. These sensors are electromechanical, basically. They detect and record when you use the inhaler, the time and date of each puff.
Just tracking usage?
Some do just that, which is already valuable. But others are more sophisticated. They might have sensors to measure your inspiratory airflow checking if you breathed in strongly enough for a DPI, for example.
Wow.
Or they might detect if you actually shook your MDI properly before using it. Little things that make a big difference to effectiveness.
So it's the sensor, then it connects to?
Typically connects via Bluetooth to a smartphone app. The app collects the data, maybe combines it with other info like local air quality or pollen counts. Then that data often gets uploaded securely to a cloud server and potentially accessed by your clinical team through a dedicated portal.
And there are actual products out there now.
Oh, yes. Companies like Propeller Health, Cava has its DigiHaler range, Amico with Respiro, Adherium's Haley sensor. They're commercially available and being used. It's like adding this invisible layer of support and information.
So how does this help me, the person using the inhaler? What's the direct benefit?
Several things. The app can give you simple reminders for your daily maintenance inhaler, time for your morning dose. Helps build that routine.
Okay, that's handy.
You can also see your own usage patterns. Track how often you're actually taking it, maybe correlate it with how you're feeling, or environmental triggers. It gives you more ownership and insight. And crucially, particularly for the reliever inhaler, the app can track overuse. If you suddenly start needing your reliever much more often, the system can flag that up.
The red flag again?
Exactly. It could alert you you've used your rescue inhaler 10 times in the last 3 days and prompt you to maybe check in with your doctor before it escalates into a full-blown attack. It's like an early warning system.
That sounds potentially game-changing. And for the doctors and nurses.
Huge potential there, too. They can get remote, real-time, or near real-time access to objective data on how well you're sticking to the treatment plan. No more relying just on memory or guesswork.
Oh yes, doctor, I take it all the time.
Well, maybe. But more seriously, they can see patterns. Is adherence dropping off? Is the technique possibly poor based on flow rate data? Are they overusing the reliever, signaling poor control? It allows for much more timely and targeted interventions.
Is there actual evidence it improves things?
Yes. Studies are showing significant improvements. For instance, adherence rates, people actually taking their preventer meds as prescribed, can go way up. One study with children saw adherence jump from around 30% in the control group to over 84% using a digital inhaler system.
That's a massive difference.
It is, and that improved adherence translates into better asthma control. Plus, the predictive power is really interesting. Studies have shown that a sharp increase in rescue inhaler use, captured by these digital systems, can predict an upcoming exacerbation, sometimes days before it happens.
So you could potentially intervene earlier and prevent it.
That's the goal. Catching problems early, adjusting treatment, potentially avoiding trips to the ER, hospital admissions, which obviously benefits the patient hugely and also reduces overall healthcare costs.
It sounds amazing. Are there downsides? Limitations?
Of course, it's still relatively new technology in practice. Cost is a factor. Who pays for the sensors or integrated devices? User acceptability. Do people want their inhaler use tracked? Data management, handling all this information securely and integrating it smoothly into clinical workflows, that's a big task.
Data privacy and security must be concerns too.
Absolutely. Consent, privacy, who owns the data, how it's protected, these are critical ethical considerations. Though, to be fair, they're not unique to digital inhalers. They apply to most digital health technologies.
And the future. Where could this go?
The potential is enormous. Imagine combining this objective inhaler data with, say, AI algorithms analyzing patterns, linking it with data from your smartwatch about your activity levels or heart rate, or maybe a digital peak flow meter or a spirometer you use at home.
A complete personalized picture.
It's exactly. Creating a truly personalized, dynamic asthma management plan. Predicting risk much more accurately, intervening proactively, maybe even automatically adjusting recommendations via the app. It could genuinely revolutionize how we manage chronic respiratory disease, making asthma care truly proactive and tailored to the individual in real time.
Wow. Okay, so we've really journeyed through a lot here in this deep dive.
We certainly have.
From understanding what asthma actually does in the airways,
The constriction and inflammation.
through the different types of medicines, the relievers, the preventers, the add-ons, the biologics,
The different regimes like air and MART.
the crucial role of the devices themselves, the puffers, the powders, the spacers.
Don't forget the spacers.
Never forget the spacers.
Yeah.
And finally, landing in this, well, this really exciting present and future of digital health integration.
It's quite a landscape.
It really is. And hopefully you listening have gained a deeper understanding now, something that can genuinely transform how you approach asthma management, whether it's for you or maybe for your child or someone else you care for.
And I think if we connect this back to the bigger picture, it really comes down to that idea of informed understanding, doesn't it?
Yeah.
Knowledge is powerful, but it's most valuable when you understand it and can actually apply it. So the encouragement is really to use this kind of information, to engage more confidently, more meaningfully with your doctor, your asthma nurse, to ask better questions, to advocate for the best care for yourself or your loved ones, seeing your health journey not just as passively managing symptoms,
Right.
but as an active, ongoing process of understanding and collaboration.
Absolutely. So maybe the final thought to leave you with is this. How might you use what you've learned today? How can you take this knowledge about the medicines, the devices, the strategies, even these emerging digital tools, and use it to really optimize your asthma plan? Always, of course, in partnership with your healthcare team. How can you become an even more active, informed participant in your own health journey starting now?